because people have got revenue. So you can do this. The largest use of telehealth of all at the moment is teleradiology, which is not funded. It's done because it works, and people just do it as their system of delivery of care. So there are ways where you've got to make sure you can show that this makes real sense in terms of clinical delivery of services by the urgent care. We have co-payments for telehealth, which I will go into. I'm just reaching towards the end now. Organisational structure, leadership commitment, programme office, which we are to coordinate, integrate it. I spend not so much my time dealing in policy, though I help provide policy. Almost all is dealing with the problems that arise in making these services run. So you need somebody to end up helping integrate. Clinical champions are vital to be able to help smooth the pathway. Telehealth coordinators, because often when you're doing this, the problem with doing it is not that there are insurmountable problems. There are just a whole list of things that need to be done. So if you're thrusting some of these new programs on really busy clinicians who are busy doing things, you do need something to coordinate it. We managed to include it as performance monitors and linked it into committee infrastructures that went with what we were doing as well. So we have 3 national IT infrastructures. I won't talk at depth. We purchase the technology outside, but the data that comes in then links into our own internal IT system. We've interfaced some of the data. I could spend the whole afternoon, which I won't obviously talk about interface of data and some of the issues related to that. I should just say that I believe that this fundamentally needs some kind of electronic patient record. Now, the system you get may provide something rudimentary, but essentially what we're talking about is making decisions for patients with chronic disease in their own homes. If you don't have information about that patient, normally with written information, they might have charts that thick, and you wouldn't get through it. So an electronic record gives you the information to be able to make the decisions. And I think, which I'll say at the end again, what you can see this is, which is very exciting, is actually taking the computerized patient record into the home. The electronic health record, when you see it in the hospital, gives episodic data. This gives continuous data. So the ability to have continuous data in terms of how people with chronic disease are managed is going to revolutionize. We're at a very, very rudimentary stage now. But that's why this is such I won't go through the other 2 areas. So, I'd like to put to you, I mean, certainly for us, we got to the stage of having a twin-engine plane, something that goes up, flies relatively reliably, and somebody's in the co-pilot seat so I can be away, so I'm not sitting there at the front anymore. I should say a few words about that, because, and the reason I say words about that are, that is critical, that it mustn't happen. It mustn't happen in healthcare anyway, but that will be the kiss of death of the programs. So, risk management. You have to think about this proactively. If what you're going to do is start off with a pilot, and you don't intend to ever take that forward into anything more, you probably don't need to get too excited about what I'm about to say. And the reason is, because if you go around telehealth programs I do from time to time, you will find if you ask them, what do you do in the event of a systems failure? They'll say, we do what we always did. So in the background, they've got the same system that was always there, which can deliver care in exactly the same way. And so there is no cost saving, there's no efficiency, there's no reason for an organisation to buy into it. Once you re-engineered the care, so you don't have those physical systems in place, you have risks, and you have to manage those risks. So, the continuity of operations plan. We've had issues with our data security, with doing the routine scans done for things to make sure that there are no data problems otherwise. You name it, it can happen. So we've had issues where we have had to go into a continuity of operations plan. Can you imagine what would happen if you had 48,000 people suddenly stranded on information systems? And again, when you're going to look at the technologies and you think about the technologies, I almost thought at the beginning of this that my computer wasn't boot up. I could have done it. My continuity of operations plan was, believe it or not, I can actually sort of just be a human being and talk, so I could have done it from memory. But if you think about the technologies we use in information technology, that we use about the house, Many of them, would you really trust your brother, sister, mother, father, daughter, to them? So there is something about engineering these systems. So make sure they're engineered, they're not clunky because they need to be delivered in care, and you have to be driving this as a watchful consumer. Agreement stakeholders, police consultation, major funding, and the fact that you don't have double running in the background is emblematic. You moved from pilot to production status. So I've shown you that and otherwise. So if we're going to make the jump to this, what are those jumps going to be? So my last few seconds, whatever mHealth is, I don't know. All I do know is what we're currently talking about will move on to not just mobile devices, it will be ubiquitous. So the information is going to be available across platforms. We probably, and this is all my own personal opinion, I don't believe we'll probably be buying things that go into the home. We will be interfacing with people's consumer electronic devices. One of the ways this would make great sense is, believe it or not, to be on one of these machines every day getting information. For some people, they've seen this every day. So how it links into entertainment systems is probably going to be very crucial. There's going to be ubiquitous video conferencing as well. We're going to have it on our handhelds to do those kind of things. So the issue is not going to be what is the mobile, what is the device. I've talked about this is really how you extend the electronic health record into the home. That's going to have real implications for research as well. Large trials can be done on people with diabetes, where they're essentially being monitored at home, the information will be collected, assuming it gets IRB and other approvals. What we're currently doing in terms of looking at the data is very big. We're looking at something that alarms, which is around an event that causes issues, and red flags up data in a very simplistic way. Where this all will move will be about data where we can begin to predict what's happening, determine who's at risk, determine who are going to be the caregivers who need support, some of those other kind of things. And critical to it all is going to be how it's funded. And I just say in terms of how it's funded, because I've worked in the area of how you move services from hospitals into community and other settings for the last 20 years, and many of you have worked longer in it than I have. If this is going to work, you've got to disinvest somewhere. So the funding stream has to come from somewhere. Now, I don't think, probably, that this is going to be something where existing ways of funding are going to fund this and make it work. Things are designed to stay the way they are. I don't know who wrote that. I'm offhand. So the funding systems we've got keep things as they are. But if you reduce the throughput of a hospital, unless you can reduce the costs, all you're doing is increasing the cost per case. So they end up charging more. So essentially, the business model of hospitals is around beds and how you fill beds. So a business model has to be different in terms of what this is going to be. And so looking at things like programs of care otherwise. So I don't think I've got any time for questions, or there may be some at the end with everybody else. And I've taken my co-panelists